Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at Home welcomes Professor Nicolas Girerd in Nancy, Lorraine, France, with whom we would like to discuss evaluation of congestion in heart failure. Nicolas, we are very happy to have you tonight.
Very happy to be here.
Professor Girerd is cardiologist at the Université de Lorraine in Nancy, France, which is arguably one of the two epicenters of academic cardionephrology in France, the other being Paris, surely. One focus of Professor Girerd's work is heart failure management, particularly the diagnosis of congestion in patients with dyspnea, a field in which he has published numerous studies and review articles. So the Tour de France is back in France. Marcus at Home is back in France, both for the first time since summer 2021, when we met Professor Nassim Kamar in Toulouse. And I'm happy to have a co-moderator today who kind of symbolizes French-German cooperation and nephrology, Sarah Morell in Frankfurt, Germany, who will start this discussion with an imaginary case. My name is Gunnar Heine, also in Frankfurt, Germany.
Yes, I'd like to start the interview with a case. So a patient comes into the ER, 62 years old, male. He claims that he's been suffering from shortness of breath for the last weeks, especially at night when lying down. He's noticed edema in both of his legs and has been feeling more tired than usual. His BP is 110/70, his heart rate 95 per minute, and the respiratory rate 25 breaths per minute. So how would you proceed with this patient? What diagnostic workup is needed?
Okay, so you mentioned that the weight went up, right?
Yeah, we can.
Some weight, okay.
Yeah.
So obviously first clinical examination is key to success. So you do have to have a look to the legs to see if you do have some level of edema, and this is it pitting edema or not. Obviously try to hear something in the lungs, but if the patient is under high flow oxygen, it's sometimes a bit difficult to have a clear auscultation. Something that you can have in minutes is the chest X-ray, and that is it can be rewarding. Sometimes you see nothing, but sometimes you do see something, and I think we are nowhere close leaving this old approach, because sometimes you have a clear idea of what's going on. But the problem is that with the clinical examination and the chest X-ray, you are sometimes left with doubts. And this is actually probably 50% of patients. And those doubts translates in errors. And I will go further down that road after. But a third of patients admitted for acute dyspnea in the ER are not adequately diagnosed. The diagnosis is changing in 1 patient out of 3, which is quite a large number. And so if you are lucky, perhaps you have BNP that you can do at the tip of your finger, but it's very unusual in France because the hospital has to pay directly without any reimbursement. So it's almost never performed. What you can do, and I'm a very strong believer of this approach, is lung ultrasound, because this will improve your accuracy, your ability to correctly, adequately diagnose the cause of acute dyspnea. There's a trial that showed that actually you minimize the proportion of patients in whom you fail to identify the correct cause of dyspnea from about the 3rd to 10%. So yeah, that's a big gain. After that, you have only 1 out of 10 patients in whom you are unsure of the cause of the acute dyspnea. That's why I will focus most of my talk on lung ultrasound, because I do think that for diagnosis purposes and for prognosis, it has a major advantage over all the other approaches.
Mm-hmm. So if I ask you what the best diagnostic approach in, let's say, congestion and heart failure is, you would say lung ultrasound?
And not just for heart failure, also for the other cause of acute dyspnea, because you do, and you know, COVID highlighted this big time, because lung ultrasound is a good way to identify the lesions that you see in COVID. Actually, you can see regular pneumonia. And usually when you see nothing, it's that you have COPD, right? Mm-hmm. Because COPD does not leave traces on the lungs. It's something that is at the level of the bronchitis. So I would say clinical evaluation, chest X-ray, then lung ultrasound, and then in most instances, you're good to go. After this short talk, you can actually find back everything I will say in those two review papers. One is really focusing on ultrasound imaging of congestion. So it will cover the lung ultrasound, but also the jugular vein evaluation and the renal congestion evaluation. And this is a collaborative work with most European and American experts in that field. And then there's also an older paper that we published in JACC Heart Failure, focusing on the evaluation of congestion. So it's not only imaging, but also by the biological approach and clinical approach to congestion, and how to best implement that depending on the state of the patient, so outpatient, inpatient, etc. So this is what I referred to just minutes ago. So the most convincing evidence on the problem that we have in acute settings is actually French evidence 15 years ago, but you know, the way we are approaching dyspnea is not very different now than 15 years ago. And you can see that the accuracy in the ER using, you know, physical examination, checks, history, CT, everything is pretty low. We are good for asthma, but for the rest, the accuracy is about 75, 80. So specifically for heart failure, you missed the diagnosis in 1 in 4 patients, which is a problem because when you miss the diagnosis, the probability of dying is 3 times higher. So you have consequences of this mismatch. And so to me, the most appropriate technique to swiftly identify congestion and the etiology of dyspnea is clearly lung ultrasound. You have several techniques, and we will go through those techniques. And the major asset, the major thing that makes lung ultrasound an excellent tool for diagnosis is that it's very simple. It's actually why cardiologists don't like lung ultrasound, because it's not pretty. It's just everything is black, it's normal, everything is white and moving like lasers. It's probably heart failure. So very, very simple. It's actually another French thing, because first published by Liechtenstein. Before we said that, you know, there was nothing to see with an echo machine in the lungs, but it's untrue. Why? Because what you see is very much associated with the pressure, the pulmonary pressures that you can measure during the cath. So lung ultrasound is extremely less invasive than cardiac catheterization. And actually, in normal condition, there's nothing to be seen. Everything is black. But when you have water, you actually mix the two things that are creating echo images, something that is the kryptonite of echo images, so basically air, and something that is catching the echo imaging, so water. And this interface between water and air will create those laser-like images because of this echo interface. And you can actually quantify water doing that. So everything is black, everything is full of air. And the more white that you have, the more water you have in the lungs. So following this idea of measuring or having an approach to cardiac pressures with echo, we actually, with Professor Donald, who is a renowned echocardiographer in France, a cardiologist and echocardiographer in France, we actually saw that probably one of the best approach to those cardiac pressure is not echocardiography. It's rather long ultrasound. You can see here that indeed you have some differences in IVC, in PSP, in E over E prime, all those cardiologist stuff. But when you compare everything, doing so C-index and NRI, very classical approaches, the best score that you have is for B lines, so long ultrasound, and then you have IVC, but the PSP is far below that. And the algorithm that we use, trying to be smart, using several variables, is so from 2016, is doing far less than the very simple long ultrasound approach. This I did not mention yet, but when you use something that is combining the clinical approach with long ultrasound, you have a sensitivity and specificity that is almost perfect and an area under the curve that is almost perfect. So probably based on those data in ER departments, the best approach is a mix of clinical and long ultrasound. And you have a number of algorithms, but sometimes when you try to train yourself to long ultrasound, you will see that protocol, the Brook protocol. I want to underline that this is really for the ICU rather than for regular physicians in nephrology and cardiology and general medicine. So probably a different approach should be used in those less sick patients, and a very practical approach, just looking at the lungs and trying to identify what's going on, was actually tested in a clinical trial published a few years ago in Lancet Respiratory Medicine, and they showed that the incorrect diagnosis was reduced 3 times, so 36% to 12% in appropriate diagnosis. So that's why I mentioned 1 in 10 patients only in whom you don't really know what's going on after the long ultrasound. So long ultrasound is also a beautiful prognostic tool. So we do know that congestion is bad for patients. It's the main cause of hospitalization, but we do know that residual congestion is bad for you. The risk of hospitalization is higher. The risk of dying is much higher. But this is with clinical congestion. And if we measure congestion in a better way, in a more efficient way, probably the association is better. And we show, so for echo, we do have that. So we do improve our evaluation of congestion with echocardiography, our prognostication with echocardiography using the IVC, using the E over E prime, so very, very simple echocardiographic assessment. But you will actually do better using just the IVC. And this is important. Why? Because the IVC is simple. It can be managed by, non-cardiologist physicians. It's very simple to learn. And you can see here that the prognostication that you have with this very simple IVC measurement is actually better than what you have with the more complex echocardiographic variables. And this is even true for a very simple biological tool that no one uses. Probably it should be widened, but it's the plasma volume estimation that you can have in the ER everywhere, actually, where you measure, hematocrit and hemoglobin. And you can see here that the prognostication that you have with this measurement of congestion, just using the blood count, is actually even better than what you have with echocardiography. So you don't need to go into the complexity of echo probably for the congestion evaluation resulting in better prognostication. So if you want to read more about plasma volume, we did this review in actually the German cardiology journal, CRC, and I cannot go into more details today, but you will have readings. And now let's look at the prognostic value of B lines or of long ultrasound. As you can see here, the prognostic value is enormous, especially at discharge, when you did your best to decongest the patient, and the curves that you see here are very different from the curves from the clinical evaluation, right? Because you have a clearer view of the residual pulmonary congestion of patients using long ultrasound than just using your stethoscope. So this paper was cited already 200 times, I think. And we did that 6-7 years ago now. So the probability of being re-hospitalized, of dying in the 3 months following an hospitalization for heart failure is less than 10% when you have not a lot of B lines. And it's about 80% when you have a lot of B lines. So very, very strong prognostic value. And as it is very low tech, it works regardless of the context. Because you just look at the water in the lungs. So the patient is in AF or low LVEF, or the timing of hospitalization doesn't really matter because it's very low tech. You're just asking whether the patient has water in the lungs or not. And so the value of this measurement is very good regardless of the context, which is not true for echocardiography. Your cardiology friend will say, oh yeah, but the patient is in AF, so it's complicated. And yeah, nothing like that for long ultrasound. It's low tech, very simple. You do have a prognostic value in ambulatory patients. So this was published by Elke Platz. So actually a German a physician that went to the US, I think at the end of internship, but German approach. So European Art Journal 2016, and she nicely showed that the association of long ultrasound measured in an ambulatory setting with the risk of hospitalization for heart failure is very, very important, big. Even more so in patients with a normal auscultation, longer auscultation. So it do improve your approach of patients with normal physical examination. So it's really an incentive to go beyond physical examination. So more than 3 lines using an 8-zone approach, it's 4 times higher risk of hospitalization. So we did a meta-analysis. I cannot go through all the papers, but basically the prognostic value, regardless of the setting, outpatient, admission, discharge, is fairly good. And you actually have evidence that treating patients according to long ultrasound is good for patients. 3 trials, moderate to small size trials, but all saying the same thing, that you divide the risk of being hospitalized, of dying, by 2, treating your patients according to long ultrasound, and so very strong statistical significance, no heterogeneity. Apparently it's really that. We need a bigger trial probably to make it, the usual way of treating patients, but there is already strong evidence supporting this approach. This is from the congestion evaluation through the patient journey. I will not go into details, but mostly long ultrasound is almost everywhere here. When you have the patient in front of you, obviously in patients that are followed distantly, long ultrasound is more difficult to perform. And this is the overall algorithm for the imaging or evaluation of congestion, let's say, including imaging, so the long ultrasound, but also the jugular vein and the renal venous Doppler that will give you even more useful information on your patient. This is mentioned in this review paper with experts from all over the world. So we do explain how to do long ultrasound. I will go into a bit more details and show you some loops. So first, how to position the probe, because first things first. So you have two options. Either you go for a parallel to the rib approach or perpendicular to the rib approach when using an echocardiography probe. If you have an abdominal probe, obviously you can use both approach, but it's less of an issue because you will have a very, very large image with this kind of probe. So it's less important the way you position the probe. The pros of this approach, parallel to the ribs, is that you will have more pleura that is visible. The pros of this approach, perpendicular to the ribs, is that you will see the costal grid, so the ribs, and you cannot think that the pleural line is the rib, because you see both the pleural rib, the pleural line and the ribs. So for a beginner, it's a no-brainer. You do that, it's impossible to fail, not to know what you are seeing, because you will have a very clear image. You will see that. So basically, you have the ribs here, nothing behind the ribs, because it takes all the ultrasound, and in the middle you have the long, and the line that is just below the rib, it's the pleural line. So it's very, very easy to be sure of what you are seeing on your screen doing that approach. The second approach is that one, so longitudinal approach. Then you will see indeed the pleura, and you will even be able to see this sliding. You can see that actually the pleural layers that are moving because of the inspiration and expiration. So you will have a very detailed view of the pleural line. So you will not see shadow because you do not have the ribs on your screen, so no shadow. And to use that, you just need a bit of experience. It's very simple, but at the first exam it can be tricky, but then you will gain experience, and it will be a no-brainer. And you need to move your probe to be able to differentiate what's the rib and what's the pleura, the pleural line. But it's part of the ultrasound skills. So as I mentioned, very, very simple techniques. So you see that you can already say that it's normal because you don't have these big laser that are moving during the inspiration and expiration. Here you do see the pleural line that is moving because of the pleural layers moving. you have this A line, this horizontal line here, and you do not have those vertical laser-like images that are moving. So this is normal. So when you see nothing, almost nothing, it's normal, very simple. Here, you do see, and this is acute dyspnea. Now you can tell from what you see that it's moving fast because the patient is breathless. You see those white images that are appearing and disappearing, and basically it's water moving. So you can say right away that it's not normal. Here, the same. You know, in the middle of the dark, you see those very bright white images, laser-like, that are moving, and so you have something. You have either water or pneumonia. The only difference that you make between the two is that when you have a lot of B lines in just one place and nothing elsewhere, chances are that you have pneumonia, right? You have something going on in a specific spot. Whereas when you have problems everywhere, then it's more likely to be a heart failure because it's a pressure problem that is applying to the entire lung. So this is a 3B line score, and then you can go into more problems. You have more things. So from the start, you will say here that it's not normal. You do see things going on, right? But having some level of quantification is useful. And in that case, it starts to becoming a bit difficult to grade and to count the B lines. The approach that we have for that, it's a regional approach. You try to identify the proportion of the screen that is getting white during a respiratory cycle, and actually the human brain is very good for that, for the interpolation of images. We are good with that. So here, if at the first, this is in French, sorry. So at time 1 and time 2, you have those images, you will be able to do the math in your head to say, yeah, that's approximately a third or 40% of the screen. So let's give a score that is 3 to 4 out of 10. The maximum score that you have is 10 in one loop, in one zone. So this is semi-quantitative, but actually highly reproducible because it's not a very skilled method. It's not. It's really a proportional method that actually works pretty well, reproducibility-wise. And this is useful for this kind of images. You do see why things happening everywhere. So yeah, most of the screen is going white, so your scoring would be very high. Actually, you cannot see really one zone that is clearly not white during the cycle. So you would probably give the maximum score here, or 9 out of 10 perhaps. So now you know what to do with one loop. That's already something. Then how many loops do you need? How many times do you need to go on the chest to have an idea of what's going on? There are tons of techniques. So you can have 4 points, 6 points, 8 points, 28 points. And in the 8-point technique, several things can be used. Let's keep it simple. The best approach for diagnosis or prognosis is 8-point using a supermedial approach. So it's the 8-zone approach using fixed points. So on the second intercostal space close to the sternum, then you go to the second intercostal space in the anterior line, axillary line, and then you go to the 4th intercostal space, and you do the same, and you do that on the right and on the left. So 8 points. And with that, you're good to go both for diagnosis and prognosis. So it's clearly the best approach. I'm saying that based on this study in which we did the 28-point method in breathlessness patients in the ER in difficult cases in which we were unsure of the diagnosis. So it's the maximal approach that you can have to compare the techniques. And so you have thresholds for prognosis that are more or less the same. It's the 3 B lines for 8 zone. It works for discharge and it works for outpatients. So the magical number for the zones, the number of zones that you have to measure, it's 8. And the number of B lines that you do not want to see is 3 and higher. So we're done for the long ultrasound. Obviously, you have to test it. You have to implement that in your practice, but very simple. And now you have the most important ideas in mind. Then the jugular vein. So very simple again. Jugular vein should be small. So nephrologists tend to think it's huge, but it's huge when you put a cath in it. But the normal people, they just have 1 millimeter maximum jugular vein. And when you do a Valsalva, then the jugular is increasing a lot during the Valsalva. Why? Because a small amount of pressure will increase the blood volume that the vein can take. But when the baseline pressure is higher, the jugular vein is bigger, and the increase that you have with Valsalva is smaller because the vein is already full. So very, very simple, pragmatic approach. And you can either do TM measurements like that, but you can, and actually I'm not using that because I have a ultra portable echo machine and I do not have that. I'm just measuring what I see on the screen, or even eyeballing it on the screen. If you have changes that are marginal, like here, the jugular vein is becoming just 2 times bigger when you do the Valsalva, then you have a baseline pressure that is elevated and you have hemodynamic congestion. So quickly, very simple, jugular vascular probe on the neck, as high as possible near the jaw. You go down until you see the jugular vein. If you see nothing, perhaps it's just that the jugular vein is so tiny that you cannot see it, so you do the Valsalva. You apply gentle pressure because, a vein is so compressible that if you put pressure on it, you would see nothing. And so you, expiratory phase, then Valsalva or leg raise in patients that are unable to do Valsalva, then inspiration, and you will have a clear idea of the systemic pressure of the patient. So very simple. I'm using that with a ultra portable machine, and it's very, very quick to do during the consultation along with the long ultrasound. The next technique is a bit more difficult, to be honest. It's the measurement of what's happening in the kidney. So we have, at least I hope for us, a continuous venous flow in the kidney, meaning that the blood is going out of the kidney during the entire cardiac cycles. Why? Because the pressure is low. It's easy to go outside of the kidney. But when the systemic pressure is increasing, then you have a discontinuous flow. And when the level of pressure is very high, you have a monophasic discontinuous flow, meaning that the blood is not going out of the kidney. So the kidney pressure is going up and probably the renal function is going down. And this is why we have such a huge association between congestion and renal dysfunction in acute heart failure, probably because of that. So we are basically imaging why we have renal problems when we have acute heart failure. So as I said, a bit more tricky, unilateral on the left, you need to decrease your speed when you're a cardiologist, because here it's venous flow that you want to measure. So it's really not the flow, the speed that we are used to in the heart. You want to image the periphery of the kidney, the interlobar arteries and veins. So basically not here, you want, somewhere in the middle of the kidney, over here. And you need, and this is probably the trickiest part, to have a breath hold, because it's so tiny speed that the movement of the kidney along with the respiration is difficult to integrate. So you need to have a 2 or 3 second breath hold to measure it correctly. So very interesting. You have those very distinct phenotypes. And so, yeah, just to show you more precisely. So this is your target, right? You don't want to measure this far because it's very, very difficult, but this is okay, right? You don't want that. The segmental, it's really, you will have this artery that is too difficult to integrate. But here, the veins are easier to measure. And it is related to a lot of cardiac variables, fancy cardiac variables, to BNP, and it has very strong prognostic value. If you have a continuous renal blood flow, venous blood flow, chances are you will not have an hospitalization or die in the year after this exam. If you have a monophasic blood flow, then chances are you will have problem, 80% of events at 1 year. So very, very strong prognostic value. As for long ultrasound, congestion is really bad for heart failure patients and for kidney failure patient that would go through dialysis for not dying. So I'm a very strong believer of portable echo machines, and actually I have that on me all the time. So it's a bit costly, but very useful and rewardful. And I think that in 10 years, this will be more standard to have this approach, using echo every now and then in consult in hospitalized patients. It will be easier. So, evaluation checked. I said I will briefly mention treatment, but very, very briefly, I just want to mention one point. Again, one review that we published very recently involving the heart failure working group of the French Society of Cardiology, published in European Journal of Heart Failure. So we mentioned the diuretics, the loop diuretics, obviously the thiazide, everyone know that. We emphasized the diuretic effect of mineralocorticoid receptor antagonist, MRA, so Spiro and epraverenol. This is important, especially in hospitalized patients, because you can use coronat in hospitalized patients. And, it's a very, very old drug, but you will have an immediate effect. And so probably it's useful in patients that are hospitalized for congestion. And we also emphasized the effect of SGLT2 inhibitors that do increase the natriuresis. And it was actually shown in a clinical trial specifically designed to show that. But it's really the use of all those drugs that result in adequate decongestion, treatment of congestion. The most important part of this review, of this approach, is trying to get rid of congestion in an outpatient setting, either in the hospitals or in hospital-at-home settings. And this might be a bit unusual to you. So we have designed a roadmap. Basically, patients that need oxygen, they have to go to the hospital, obviously. Patient that you don't know, it's the first heart failure hospitalization. Yeah, you need to have the patient in the hospital. But in patients that have been hospitalized for several times, you know them, you know that they are at high risk of having a worsening heart failure. You have trouble just with the oral diuretics to get rid of congestion at home. Then you need to go IV, but you can do IV either at home or in day hospital sessions. So this is those patients that are targeted by this approach. You need to go fast, because if you wait, the patient will go to the hospital in the end for a regular hospital stay. So you need to be able to do one or perhaps several sessions during one week. And when the patient is decongested, then you need this holistic approach that will decrease the risk of rehospitalization or recongestion, actually. So we did a nice figure showing what could be. So this is not dialysis. Perhaps it's a bit like your dialysis, hospital, but this is just to do the IV diuretics, and we have done a bunch in our place. I know I discussed this 2 weeks ago with an Israeli colleague, and he has like a whole ward of that with 40 patients a day going to the hospital to have their 3 or 4 hours IV diuretics and going back home. So really pretty much like dialysis, right? Just cheaper. But and you have this algorithm that is, so if the patient has a low maintenance furosemide dose, then you will go slow on the doses. Usually the patient that we have, it's more those patients with high doses of diuretics, and oral diuretics does not work anymore, and you do mega bolus, 200 milligrams of bolus, and then an infusion for 2 to 3 hours, and you usually add also a thiazide to those infusions. And you have a look to the potassium, obviously, and you try to add all the drugs needed to try to decrease the hormonal problem that we have in heart failure. So you want to decrease the activation of the RAS, and you want to use SGLT2 to try to decrease the demand, decrease the need for diuretics, and then you monitor the patient. So it can be done in the hospital or in day hospital settings. It can be done at home too. And you actually can use subcutaneous forms of furosemide too. So really, I think that we will translate our system to that in the next few years, because in Europe, in the US, I think it's a worldwide situation. The hospital beds are difficult to find, less doctors, less nurses. So this approach is probably a good way to cope with the difficulties that we have in the hospital. So a big thank you. I hope that it will answer some of your questions.
So you've promoted a lot the lung ultrasound. Let's say we have a young colleague in the ER who hasn't a lot of clinical experience, who hasn't done a lot of echoes. So he has a patient in the ER with congestion and heart failure. So would you say that this colleague should do just a quick echo and instead do a lung ultrasound and focus on the IVC, for instance?
The most rewarding in front of dyspnea without shock, right, with pretty normal blood pressure, is lung ultrasound by far. Then it's probably IVC, and then it's probably looking at the veins in the legs. Mm-hmm. But I would say that first doing the 8th point, then going at the rear of the lungs to see if you have a pleural effusion or a posterior pneumonia. So then you have, the image of the entire lung, nothing there. Okay, so you can, if you want, go to the IVC, but if you have really a normal lung ultrasound, it's not so much rewarding. It's rather, if you do not know how to do lung ultrasound, IVC is probably the next best thing. But here, if you have a normal lung ultrasound exam, I would actually go for the legs, because if you have a thrombus in one of the veins, then you are in front of pulmonary embolism. So this is more rewarding than trying to look at the heart. Yeah, the EF is low, but the patient, we know he has FREF. So you can have FREF and being hospitalized for pneumonia, very frequent, for pulmonary embolism. Knowing that the patient has a low EF is not really helpful.
But again, we would still need X-ray examinations in these patients.
Oh, yeah.
So this does not completely actually changes everything. So we would focus upon ultrasound, but you would still recommend the colleagues to do one X-ray admission.
Correct. Very quick, and it's an addition to what we do. It's not replacing everything. And you need to have a look to the patient. I do think you need to have this physical examination because we are skilled to identify problems with physical examination. We can have a look to the chest X-ray, but let's do the lung ultrasound too.
Yeah. And as you told us in the beginning, surely also the history of the patient, and that's something which gets somewhat lost in modern medicine, that you really take some minutes and ask the patient at least some questions, what happened in the last days and things like that. I would have 2 or 3 final questions. My first question would be again with regard to inferior cava vein echo. I find in the literature some different recommendations where exactly to do the measurements. So some experts recommend right where the cava vein goes into the heart. In your paper, you rather recommend 1 or 2 centimeters distal to the juncture. So where should we actually do our measurements?
Usually you need to be not at the, just close to the heart, because sometimes it's not like a tube, it's like a triangle.
Yeah.
So measuring in the triangle is not a good approach, because usually this is, there's remodeling going on. So you are not really measuring the pressure, you are probably rather measuring remodeling that is increasing over the years. So that's why you need to measure a tube. If it's not a tube, then you have a problem, because depending on when you measure, you will have a different measurement, right? So you have to tilt your probe up until you have a parallel borders for the vein.
That's very important. Thanks, because again, we always find very difficult if we have this triangle where to measure, and then you would really do the measurements at the basis of the triangle, so before it gets narrow, and that's more reliable than for the reader. My second question would be, what about inter-reader variability? So surely if you do have 2 or 3 doctors, they will not get the exact same measurements. So how stable are the findings for these different techniques?
So for lung ultrasound, I can say that it's very good. Depending on the studies that we did, it's 0.85 to 0.9. And the Italian teams, they have the same numbers. So very good inter-reader, alignment, let's say. And actually, sometimes if you do the exam again, you will not have the exact same number, but it's because you're not at the exact same place. You are not measuring the exact same spot in the lung, but you take several measurements, several spots, 8 spots. So this will, like equalize. You will have a clear view of the overall state of the lung using this multi-spot approach, 8-zone approach. So very good. For the jugular vein and for the renal measurements, I cannot provide those reproducibility figures because, you know, long ultrasound is not very widely used, but jugular and renal, it's really almost never used. So we do not have this kind of data yet.
So my last question before you take Sarah Morell back to Lorraine would be the number of commits that you do measure must in some way depend on the size of your transducer. So if you use a rather small echo transducer, you should have a lower number of commits than if you use a rather large abdomen transducer. And when you do have this cutoff values like say below 3 or below 5 or whatsoever, how do you account for the differences in size of the transducer?
It's an excellent question. You're actually an expert, apparently, because it's a very, very, you know, appropriate question. And so I was not, I'm using a cardiac probe. And so we are only having one intercostal space, right? But indeed, in the ER, when you use the abdominal probe, you should keep this one intercostal space, because if you measure 4 or 5 intercostal space, yeah, you will have B-lines all over the place, even if you have just one tiny B-line in each intercostal space. So choose one intercostal space and you measure just that one, because otherwise it will increase your numbers dramatically without the patient having more water. It's just that you are measuring more lung.
So admittedly, we're not yet experts when it comes to lung ultrasound, but surely after your talk, we will do this much more often. We try to do the vena cava echoes quite often, and it's very helpful, not only in emergency room patients, but also surely in dialysis patients to kind of find their weight targets before and after dialysis. And I'm really positive that it's helpful. So thanks a lot, Nicolas. This is the end of the academic part of our interview. And I now pass back the microphone to Sarah, who will switch over to French to discuss with you the nicest spots to see in Nancy and in Lorraine.
J'ai juste une petite question culturelle pour finir. Donc, quels endroits faut-il visiter quand on est à Nancy et dans les alentours?
Donc déjà, la Lorraine, c'est un peu anachronique, hein, parce que maintenant, on est dans la région Grand Est, hein, avec l'Alsace et la Champagne-Ardenne. Donc, bon, dans la Lorraine historique, on va dire, hein, pré-grande région, il y a un certain nombre de villes. Bon, les villes les plus importantes, elles sont listées ici. Moi, je suis de Nancy, donc je vais principalement vous parler de Nancy et puis un peu des Vosges, avec la place Stanislas, qui est vraiment probablement le fer de lance de la ville de Nancy, tout particulièrement depuis qu'elle a été rénovée il y a à peu près 15 ans. Et de nuit, c'est vraiment extrêmement sympathique, avec des éclairages, il y a plein de bars, de restaurants sympas. C'est un coin vraiment très agréable pour les longues soirées d'été. Une des particularités de Nancy, c'est le fait que c'était un haut lieu d'architecture et d'art hein, pendant la période Art déco. Alors, c'est pas Art déco, hein, c'est vraiment École de Nancy. C'est une sous-spécification, on va dire, de la période Art déco, avec du mobilier que vous pouvez voir ici. C'est assez inimitable. Hein, bon, voilà, vous avez des lampes aussi qui sont assez faciles à identifier, comme vous pouvez le voir ici. Il y a de l'architecture. Alors, Nancy n'a pas réussi, je trouve, à suffisamment mettre en avant ce patrimoine architecturel, contrairement, par exemple, je ne sais pas, à Barcelone avec Gaudi, et tout le monde sur Terre quasiment sait qui est Gaudi. Bon, on n'a pas eu cette chance avec Émile Gallet, mais il y a en tout cas des constructions architecturales qui valent le détour, avec notamment des portes, comme vous pouvez voir ici, qui sont bon, de qui vous coûterait un peu cher à faire aujourd'hui par un artisan, hein, globalement, parce que le niveau de détail et de courbe est assez extraordinaire, et avec des vitraux aussi qui étaient particulièrement reconnus. Donc j'ai mis quelques spots ici intéressants, mais la Villa Majorelle, le musée de l'École de Nancy sont vraiment des lieux intéressants. Il y a même des rues entières finalement qui sont classées patrimoine historique, notamment la rue Félix Faure, parce que il y a un certain nombre de maisons de ce type-là que vous verrez en enfilade. Comment ne pas parler de gastronomie quand on est en France? Donc deux solutions avec deux budgets un peu différents quand même, hein. La brasserie qui est juste en face de la gare, sur la place d'ailleurs de la gare qui a été rénovée et qui maintenant est très agréable, qui est justement une très grande salle École de Nancy. Hein, vous pouvez voir ici notamment le plafond et les moulures avant le plafond qui sont assez impressionnantes, avec les vitraux qui sont d'époque, et avec un jeu de miroir qui permet vraiment d'être dans cette ambiance intéressante École de Nancy au 19e. Alors, le deuxième restaurant, il est intéressant pour la gastronomie, hein, une étoile au Michelin, c'est la Maison dans le Parc. C'est un cadre très sympa, alors qu'il n'y a pas le même bagage historique, hein, que la brasserie Excelsior, communément appelée le Flot par les Nancéens, parce qu'avant c'était la brasserie Flot. En tout cas, pour la Maison dans le Parc, c'est quand même très sympa, notamment l'été, parce que vous êtes vraiment dans le parc de la Pépinière, et du coup, voilà, ça donne cette fraîcheur et cette verdure alors que vous dégustez des plats savoureux, et donc c'est vraiment très sympathique. Il faut réserver assez longtemps avant quand même, hein, c'est un étoilé Michelin, donc il faut être relativement organisé. Voilà, et comment ne pas parler des Vosges? Alors ça, c'est pas dans Nancy, hein, c'est à 1h30 de Nancy. On reste en Lorraine avec les lacs vosgiens, le plus connu étant celui de Jugular, mais il y en a plein, avec des forêts qui sont très différentes, hein. C'est très très variable, les Vosges. Il y a du conifère, mais il y a aussi plein de forêts de feuillus. Si vous marchez pendant 5 heures, vous allez du coup voir des paysages qui sont très différents, c'est vraiment sympa. L'hiver, bon, moi qui suis au Savoyard d'origine, du coup, le ski de piste, je ne pense pas que ce soit l'attrait principal des Vosges, mais pour le ski de fond, et les raquettes et les grandes randonnées, c'est vraiment génial. Et sur le plan gastronomique, alors c'est pas très bon pour les artères, mais le Jérômé, qui est le petit nom du Munster local, et le gendarme, c'est des valeurs sûres de la gastronomie. Bon, et vous aurez mérité, après avoir fait du ski de fond, avoir marché pendant des heures, donc ça va. Le bilan sera, on espère, à peu près neutre. Voilà pour les joyeusetés à découvrir en été ou en hiver, en fonction de vos disponibilités.
Super, merci beaucoup. On saura où aller.
Alors, merci beaucoup, Nicolas, pour être avec nous ce soir. Merci pour initier toutes ces études, pour écrire tous ces articles, et aussi pour partager toutes les photos avec nous. Et j'espère qu'on va se revoir un jour ou à Nancy ou à Francfort. La semaine prochaine, le tour va traverser les Alpes pour arriver vendredi à Saint-Étienne, où nous allons rencontrer professeur Bertoletti, avec lequel nous voulons discuter le traitement des thromboses dans les malades atteints du cancer. Bonne soirée à toutes et à tous. Merci.